Welcome. Good afternoon. We're excited to have another series of patient case discussions today. My name is Suresh Ramalingam. I'm a thoracic oncologist at Emory University's Winship Cancer Institute. And today I'm joined by a fantastic panel of multidisciplinary experts focused on thoracic oncology. And I'm going to allow them to introduce themselves. First, let me start with Dr. Michelle Ginsberg.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging and Vice Chair for Education at Memorial Sloan Kettering Cancer Center, and also Professor of Radiology at Weill Cornell Medical College.
Hello, I'm Dr. Seth Force. I am the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
Hi, thank you, and good day. My name is Dr. Wally Curran. I'm a radiation oncologist and the Global Chief Medical Officer of Genesis Care and Professor Emeritus at Emory University.
Hello, and good afternoon. I'm Tom Stinchcomb. I'm a thoracic oncologist at Duke Cancer Institute.
We're going to go over some very exciting cases. We have a wide array of cases today that represent important clinical considerations and contexts that we face in our clinic. Patient is a 48-year-old woman who had never smoked cigarettes. The patient is presented with epithelial mesothelioma. And I'll walk you through the history. And the question we're going to try to address is systemic therapy in a situation where there's recurrence of disease. So this patient presented with progressive dyspnea, had good performance status leading up to that point. And for the patient history, there were no significant comorbid conditions. Patient didn't have any family history of lung cancer or mesothelioma. She worked in a human resources department for a construction company, no history of smoking, as I mentioned earlier. Here are the imaging findings. This was a CT scan of the chest and abdomen done in February 2021. And I'll invite Dr. Ginsberg to talk about the findings to us.
We see that there is large pleural effusion. It extends all the way to the apex. But surrounding this effusion, we have pleural thickening, and it's a mass-like circumferential pleural thickening that's very typical for a mesothelioma. In addition, we have mediastinal lymph nodes, which demonstrate enlargement in the paratracheal and retrotracheal regions.
These are additional sections of the imaging that was done at the time of diagnosis. Dr. Ginsberg, anything here that we would want to be aware of as we think about treatment decisions for this patient?
Well, it's a very large effusion, which in fact causes some cardiomediastinal shift. The pleural thickening is seen. It's a little bit hard to see whether there's invasion through the diaphragm or in the mediastinum on these images because of this large effusion. I see that the chest radiograph on your left demonstrates that a pleural catheter has been placed, and the pleural effusion is markedly decreased with only a small amount of fluid remaining. So it might be useful to get another study at that point when the effusion has been removed to see exactly the involvement of the pleural thickening.
Thank you. So at the time of presentation, the patient underwent thoracoscopy with biopsy of the parietal pleura, also underwent a talc pleurodesis, and that's when the diagnosis of epithelial mesothelioma was confirmed. And at this point, I'm going to invite Dr. Force to talk to us about the role of surgical intervention in a situation like this.
Yeah, so I think we all know that the outcomes for mesothelioma by stage really pale in comparison to lung cancer. And so when we're looking at, who we're going to operate on, patients who have malignant pleural mesothelioma, there are three main check boxes to look at. One would be, does the patient have an epithelioid type versus a sarcomatoid? We invariably do not operate on patients with sarcomatoid mesothelioma because the surgery does not seem to affect the poor outcome that they have, or not in a positive way. The second would be advanced stage cancer. So really, we really only operate on early stage mesothelioma, again, because the surgery has not been shown to really improve long-term outcomes. I think this patient was probably an exception because of her age, but I think really in a patient with multiple mediastinal lymph nodes, you can see she has really bulky disease. Her pleura is thickened beyond what most of mesothelioma is. I mean, I don't know that we would offer this patient traditionally an operation. Again, they have a high incidence of recurrence. And the third would be comorbidities or performance status. So, if you go down the list, this patient seemed to check 2 of the boxes, but has a major box that is not checked, and that would be an early stage cancer. So, I think it's questionable whether you offer a patient like this an operation, and because it's a very morbid, risky operation. So if it's not going to benefit them, then it's only going to be, risk and morbidity without benefit.
Dr. Force, when we talk about surgery for meso, there is extrapleural pneumonectomy, or there's the pleurectomy decortication approach. Can you talk a little bit about the pros and cons of these two, and which is a preferred method in your practice?
Sure. So as Dr. Ramalingam mentioned, there are 2 main operations. The standard has been an extrapleural pneumonectomy, which is a very large operation that involves removing the entire pleura on the involved side, the lung, the pericardium, and the diaphragm, and reconstructing that. It's a massive operation that has its own morbidity, and that has led to other approaches to be evaluated, namely the radical pleurectomy, where the patients have the parietal and visceral pleura stripped off the lung. So some studies looking at that have shown equivalent long-term survival, but the question is whether that's because one operation is better than the other, or they're the same, or is it just that the disease is so severe that doesn't really make any difference what type of operation you do. Obviously, when we're doing any kind of cancer surgery, we're looking for margins. And the problem with mesothelioma is there essentially is no margin. The pleura is less than 1 millimeter thick, and you're stripping that away from the chest wall. So that's your margin is the pleura. And in cases like this, where it tends to be from the apex down to the diaphragm, there's only so much diaphragm and you can take out. So it's very difficult to get R0 resections with mesothelioma surgery. Our standard has been to do an extrapleural pneumonectomy because, mainly trying to get out all the disease any other way is very difficult. The exceptions have been with localized or limited mesothelioma. A pleurectomy, in my mind, is a better way to go. Or if there's no visceral pleural involvement, only parietal pleural involvement, a parietal pleurectomy is very easy to do. A visceral pleurectomy is not so easy to do. The other advantage of an extrapleural pneumonectomy is you can more easily perform adjuvant radiation therapy, which again, because we're not getting great margins and our recurrence rates are very high, I think that the trimodality approach of chemotherapy followed by surgery followed by radiation has been shown to have the best long-term survival. Although it has been shown to be done, especially at places like Sloan Kettering, that you can radiate the pleura with the lung still in there. It's very difficult to do that without causing a lot of radiation injury to that lung.
Dr. Force, thank you. That was very helpful to think about those 2 procedures and which one might be more appropriate. One question that often comes up as well, the patient is not surgically resectable right now. Is there a role for some sort of a preoperative systemic therapy or local therapy and subsequently have a better chance of achieving a resection? Is that an approach that is supported by evidence? Is that something you think about for selected patients?
So, this is where, in my mind, mesothelioma differentiates from lung cancer. In lung cancer, that has been shown in certain patients, you can do that. That has not been shown, to my knowledge, in malignant mesothelioma. And the standard approach, even for stage 2, would be to give neoadjuvant therapy, even for what would be considered an early stage cancer. So, unlike lung cancer, even early stage 2 mesotheliomas, we recommend chemotherapy and trimodality therapy. So in my mind, you can't really downstage a malignant mesothelioma, offer them surgery, and expect to have a different long-term outcome than if you didn't operate on them.
Thank you. Dr. Karan, this patient ended up with ultimately an extrapleural pneumonectomy, had epithelial mesothelioma. The perivascular margins were positive. The tumor extended to the underlying lung, invaded the diaphragm, but did not go through it. And there was also lymphovascular stromal invasion extensive nodal disease, 16 out of 36 nodes positive, subcarinal and hilar nodes. So if this patient were to have a conversation about, now that I've had the surgery, what should the role of local therapy be? What would you guide the patient with?
Dr. Ramalingan, as Dr. Force said, even with that aggressive surgery, this patient is at high risk for recurrence and is at high risk for intrathoracic recurrence. This is probably one of the most difficult surgical procedures from the point of view of both the surgical team as well as the patient. Many people will say that having an extrapleural pneumonectomy is a diagnosis unto itself that needs to be managed. So assuming that the patient makes a good medical postoperative recovery, this is a patient who should be evaluated for hemithoracic radiation. Obviously, there's some anatomical challenges to it, but the lung has been removed. The margins are positive in multiple sites, and an aggressive approach to either delay the time to recurrence or reduce the risk of recurrence would be to think about both chemotherapy followed by hemithoracic radiation.
So the first step would be systemic chemotherapy before we consider radiation.
Yeah, I think as long as the patient's medically recovered to get chemotherapy, I would recommend that. I don't think there's one guide as to what the best sequencing is, but you would not want to do it concurrently. That would be too aggressive for this kind of patient. And I would favor the chemotherapy regimen for some number of cycles followed by evaluation for radiation.
Great. So this patient did start chemotherapy with carboplatin and pemetrexed. Dr. Stinchcomb, what sort of chemotherapy regimen do you use? Is this your go-to regimen, or would you go with cisplatin-based regimen for this situation?
Thank you, Dr. Ramalingan. I think you can either use the cisplatin and pemetrexed combination or the carboplatin and pemetrexed combination. I think for patients who are cisplatin candidates, I prefer to use the cisplatin and pemetrexed candidate. But as Dr. Curran and Dr. Force have alluded to many times postoperatively, these patients are frail and are still recovering from the surgery. So in that setting, it seems very reasonable to use the carboplatin and pemetrexed as this physician did.
And how many cycles of chemotherapy would you plan for this situation, Dr. Stinchcomb?
I would probably plan for 4 cycles at this point. Our local practice pattern has been generally to do them before the operation, where I do 2 cycles and get a scan, do another 2 cycles, and then go to surgery. But I think 4 has been my practice. There's not a lot of evidence-based medicine in this situation.
Would there be any consideration for adding an anti-VEGF targeted therapy agent to chemotherapy in this situation?
There can be some consideration because we know from trials of cisplatin and pemetrexed and bevacizumab versus cisplatin and pemetrexed in unresectable mesothelioma, there was a slight but statistically significant benefit for that, and I think that could be a consideration. I think that I would probably just go with chemotherapy and pemetrexed because I think in the unresectable patient population, the addition of Bev was a relatively modest addition. And I worry about additional toxicities from the bevacizumab.
That's true. And particularly if you're considering thoracic radiation, as Dr. Curran mentioned, use an anti-angiogenic agent and then go with radiation that might put the patient at higher risk for some toxicities and TE fistula kind of issues, I think. Unfortunately, while the patient completed 2 cycles of chemo in December 2020, within 2 months, the patient comes back with radiographic findings of disease progression. This is the image Dr. Ginsberg had interpreted to us a bit earlier. So in this situation, when the patient is progressing through chemotherapy, what would the next step be, Dr. Stinchcomb, in your practice?
For the unresectable mesothelioma or recurrent mesothelioma, my first line therapies is a combination of nivolumab and ipilimumab. We've known based on a phase 3 trial that this was superior to chemotherapy in that setting. And I think it's particularly the case when this patient seems to have progressed through chemotherapy, that the immunotherapy combination offers an alternative and a different mechanism of action.
So you're referring to the Checkmate 743 study. Do you want to briefly tell us about the study design, the results? This is a new indication for this immunotherapy combination in mesothelioma.
Sure. It was a phase 3 trial that compared the combination of nivolumab and ipilimumab to platinum pemetrexed chemotherapy. It enrolled both epithelioid and non-epithelioid patients. And in the intent to treat, there was a significant overall survival advantage to the combination. And then if you look at the subsets, the difference was much more pronounced in the non-epithelioid, but they're still in the epithelioid, it favored the nivolumab, excuse me. And I think what this trial sort of exposed is what is the efficacy of the chemotherapy in the sarcomoid. The results were relatively poor for chemotherapy, and this is a poor prognosis disease. And personally, I've adopted this as sort of my first line therapy. And if you kind of look at the finer details of the efficacy results, you see that the patients who responded had a very durable response. And so the response rate overall was relatively similar, but the immunotherapy responses were much more durable, so the patients benefited more.
And would we need to check the PD-L1 expression if we were to decide to go with the immunotherapy combination, Dr. Stinchcombe?
Well, you can check it, but I don't think it really is going to help you much. And I think many times I've seen this done, it provides some reassurance, but I think the important thing is the benefit was with nivo ipilimumab, regardless of the PD-L1 expression. And we also know that from other studies that PD-L1 expression tends to be higher in the sarcomoid, so you have a prognostic and as well as a interaction with a potential predictive marker. So I don't find checking the PD-L1 helpful for me is in terms of estimating prognosis or therapy benefit.
Dr. Karan, before we knew about the recurrence for this patient, our plan was few cycles of chemo followed by radiotherapy. When you see this sort of a local progression halfway through chemo, would this be a consideration for considering, for using radiation therapy at this point before we go to the next systemic therapy?
You're talking about in the management of this recurrence?
Yes, yes.
I think the only way I would consider that would be if the patient was very symptomatic and really rapidly declining due to chest pain or other related symptoms. Otherwise, I think it's reasonable to give Dr. Stinchcombe's immunotherapy regimen a chance. If that's not successful, I would view radiation as being there for palliation. I wouldn't consider it there just to treat imaging progression. But if the patient does have symptoms that you think a kind of rapid palliative course of radiation could ameliorate, then that would be a consideration.
Great. So for this patient with a relatively aggressive disease, epithelial mesothelioma with extensive nodal involvement and rapid progression following extensive surgery, the panel is recommending the use of ipilimumab and nivolumab based on the results of the Checkmate 743 trial. So this has been a great discussion. What a challenging clinical situation.